Conduit selection in coronary artery bypass grafting remains a critical factor in determining long-term graft patency, patient survival, and the need for repeat revascularization. The choice involves balancing the superior durability of arterial grafts against technical demands and patient-specific risk factors. The left internal mammary artery remains the undisputed gold standard conduit universally recommended for bypassing the left anterior descending coronary artery. Advantages of Lima graft include unmatched patency. Long-term patency rate exceed 90 to 95% at 10 to 15 years. Endothelial function. The Lima endothelium secretes high levels of nitric oxide and prostacyclin, rendering it actively resistant to atherosclerosis, intimal hyperplasia, and thrombosis. Autoregulation. Lima actively adapts its luminal diameter to the myocardial demand of the target territory. In situ graft retains its native proximal connection to the subclavian artery, avoiding ascending aorta manipulation, reducing stroke risk. Still, there are a few disadvantages. Limited reach, primarily restricted to the LAD and diagonal branches, rarely reaches lateral or inferior targets unless used as a free graft, which diminishes some hemodynamic benefits. Flow competition, highly sensitive to competitive flow. If the native LAD has a non-critical stenosis less than 70%, Lima flow can be compromised, leading to the string sign. Right internal mammary artery utilized primarily to achieve bilateral internal mammary artery grafting, often directed to the circumflex or right coronary systems. Advantages of the right internal mammary artery graft include survival benefit. Bilateral internal mammary artery grafting is associated with improved long-term survival and greater freedom from reintervention compared to single internal mammary artery approaches. Biological equivalence shares the same endothelial advantages and resistance to atherosclerosis as the left internal mammary artery. Here are some of the disadvantages. Sternal wound complications. The most significant drawback is a markedly increased risk of deep sternal wound infections, particularly in patients with diabetes, obesity, COPD, or advanced stage. Skeletonized harvesting mitigates but does not eliminate this risk. Technical complexity. Routing requires careful planning like retrocaval or anterior to the aorta to avoid kinking or injury during potential future sternotomies. The radial artery has become the preferred second arterial conduit for many surgeons, offering a balance of handling and durability. Some of the advantages of the radial artery. Superior to veins, demonstrates significantly better long-term patency than SVGs, often more than 80% at 10 years. Versatility and handling. Thick muscular wall makes it easy to handle and suture. Its length allows it to reach almost any target vessel. Simultaneous harvest. Can be harvested concurrently with the chest opening, reducing operative time. But radial artery graft has some disadvantages. Vasospasm. Highly muscular wall makes it prone to severe perioperative and postoperative vasospasm. Patients typically require systemic vasodilators like calcium channel blockers or long-acting nitrates for months post-op. Strict target criteria. Extremely sensitive to competitive flow. It should strictly be grafted to vessels with high-grade stenosis, typically more than 70% for left-sided lesions and more than 90% for right-sided lesions. Collateral dependency requires preoperative validation of adequate ulnar collateral flow via modified Allen's test or Doppler ultrasound to prevent hand ischemia. Saphenous vein graft. Despite the push for total arterial revascularization, The SVG remains the most frequently used conduit worldwide due to its ease of use. Advantages of vein graft. Abundant availability allows for sequential grafting and reaching any distal target. Flow dynamics. Larger caliber and lack of muscular autoregulation mean it is less sensitive to competitive flow from moderately stenosed native vessels. Technical ease. Harvest is straightforward, especially with endoscopic vein harvesting, and anastomosis are technically forgiving. Here are the disadvantages of saphenous vein graft. High failure rates, prone to early thrombosis and late structural failure. Up to 10 to 20% occlude within first year and 50% are occluded or severely diseased by 10 years. Atherosclerosis susceptibility, highly vulnerable to intimal hyperplasia followed by aggressive friable atherosclerosis, which makes future PCA of failing SVGs high risk for distal embolization. Aortic manipulation requires a proximal anastomosis to the ascending aorta, increasing the risk of atheroembolism and perioperative stroke. Right gastroepiploic artery, an alternative in situ arterial conduit typically reserved for specific anatomical scenarios. Advantages: target specificity, well suited as an in situ graft for the distal right coronary artery or posterior descending artery due to its anatomical origin. Arterial durability, offers better long-term patency than SVG when grafted to heavily stenosed target. Variable caliber, size and flow capacity can be unpredictable. Spasm risk, highly muscular and prone to spasm similar to the radial artery. There are some disadvantages for right gastroepiploic artery. Surgical morbidity, requires an abdominal incision, laparotomy or opening the peritoneum, increasing surgical trauma and risk of abdominal complications.